So, welcome. Good evening, everyone. Welcome to the second part series focusing on the cytosponge jobs and how we're bringing it into our practice, and also then moving on to how we're treating Barrett's esophagus and dysplastic Barrett's esophagus we find. The first event that happened back in June, you may remember, really focused on the science behind cytosponge, as well as looking at some of the early pilot data and how the pathology is used. That show, which was hugely well received, is available if you look at the resources section on the platform below, alongside loads of other learning material about cytosponge, including a great demonstration of how to use the cytosponge itself with a lovely patient demonstration. Today, I think, is a hugely exciting part, because actually we're looking at real life data. And we're looking at how it's being used in our hospital today, and also with later on how it's going to be used as part of a research project, and looking at how it develops. We're joined by three expert faculty. We have Paul Glenn, a consultant surgeon in Glasgow.
Hi there.
That's going to be followed by my colleague Vinay Sehgal from UCH, who is going to talk to us about how he's brought it into our practice in our hospital. And finally, a really exciting talk from Massi Di Pietro, of course, who's been with the cytosponge right from the start, talking about how it's going to develop in the research field. So welcome, you three. Thank you for joining us today. And what we'll go on straight away now to is Paul Glenn, who's going to talk to us about the Scotland project.
Hi there, my name is Paul Glenn. I'm one of the consultant surgeons in the Queen Elizabeth Hospital in Glasgow. I'm an upper GI surgeon and have an interest in Barrett's esophagus. I'm going to talk today about our experience in Scotland with cytosponge. First of all, should make a note that I've not disclosed, I've not had any payments for any presentations or talks. Now, the reason that I got involved in this is my main interest is esophageal cancer, and Barrett's is a precursor of this. We don't do particularly well in Scotland, and I think these are probably reflected across the country, but there are very few patients that we find who have T1 and T2 disease. We have looked at our recommendation for radical treatment rate, and while the OGIS data set would suggest that this is up about 1/3 to 40% of patients are suitable for radical treatment, we've found in the west of Scotland that it's down as low as 25%. And I think the reason for this is not just the deprivation and the more unfit patients. I think we really are not finding disease at an early stage. So we've divided it into the more deprived area and the less deprived area. And this is all the cancers in Scotland over a 5-year period. And we can see that around 90% of them are T3, T4 cancer. Around 70% of them are node positive. Around 40% of them are metastasis positive, and that is a slightly higher positivity rate for N&M in the more deprived areas. So we're not finding these patients early. There have been some advances in the surgical treatment of esophageal cancer. I think the neoadjuvant chemotherapy, possibly neoadjuvant radiotherapy, will make a difference, or has been shown to make a difference. But actually, the biggest gain that we'll make will be in identifying these people earlier, especially now we've got access to such good endoscopic treatment and ablation of bad mucosa. So what we really want to do is we want to be shifting these T3, T4s into T1, T2. And I think that continued trawling of the referrals for endoscopy doesn't really increase the rate of early disease that we're finding. We really need to be focusing our efforts elsewhere, but we'll come back to that. When COVID started, we didn't know what to do. We were already struggling from an endoscopic waiting time perspective. Scotland has overall a population of about 5 million, and Greater Glasgow and Clyde is around a fifth of that. So about 20% of them are in our area. So multiply by 5 to get Scotland's figures. Now, there are some areas that are doing much better than Greater Glasgow and Clyde in terms of they're getting people into scope, but this is fairly reflective of the problem in Scotland. We still have, for all endoscopies, this is not just upper endoscopies, but at the end of June this year, we had nearly 10,000 patients waiting for a first scope and about 16,500 patients waiting on a repeat procedure. As I say, a lot of these were colonoscopy, but that just gives a little bit of a reflection of what we're looking at the moment. So multiply that by 5 and you maybe get an idea of what's happening in Scotland. For Greater Glasgow and Clyde, we're in the post-COVID era now. I don't know if we're about to go back into the COVID era again, but hopefully not. But the average monthly demand, now that COVID had settled down over the last maybe 3 or 4 months, had been a request for 3,600 scopes each month, and our current capacity is a good bit less than that. So we can't keep doing what we're doing. The patients who are on the repeat procedure list, unless they've been categorised as a higher priority, are still not getting done. We're going to continue to run into problems if we keep doing what we're doing. So we looked at how we could address that, and there was a number of things we thought we could do. There were some subgroups looking at capsule endoscopy or various other things, but I was involved with the Cytosponge subgroup. This was a good group. It was got together just as almost a clinical forum for Scotland, led by Scottish Government, and we looked at Cytosponge. We thought which groups we could use it in, and we had representation from all of across Scotland, and we decided that we thought there would be 2 main groups that we could deal with. We felt fairly confident with the data that was in the literature already from the trials. We felt that Barrett's follow-up would be appropriate. These patients were not getting done during our COVID period and in the COVID recovery period. So we had to, we knew a percentage of them would go on to progress. So we thought we needed to do them, and the alternative in the asymptomatic patients was Cytosponge. And we felt the sensitivity and the specificity was enough that we could use Cytosponge in this situation. The other group that we wanted to look at were esophageal predominant symptoms without dysphagia. So essentially refluxers that were getting referred up. We wanted to use Cytosponge to see if we could triage essentially to endoscopy and perhaps save some endoscopy. So we were aware that if we were doing this, it would have to be closely audited. We would have to keep a very close eye on our follow-up, and that's what I'm going to present now. When we were setting up our service, we were helped. We had nurses from Cambridge that came up and led our nurse training days. We selected about 10 patients per nurse that we wanted to get them doing the Cytosponge for. We chose patients from the Barrett's group because they'd all had scopes in the past and we were used to having this done. We actually chose nurses who were nurse endoscopists who weren't able to scope as much at that time, because we felt that they would be able to have more of a understanding of the anatomy and that of the symptoms that the patients were giving, so that they could do a more advanced nursing role rather than just simply being a technician taking a sponge. We also wanted the leadership. We knew that the nurses that were first trained would be training other nurses as we come on to that in the end. We had to look into where, when, delivery of sponges, where they get picked up from, how we get the sponges, how we select the patients. We've got the results that are coming in. What do we do with that? Who deals with that? And then we had to work out a follow-up. And as I say, we had their eye on expanding this out and maybe using it in other roles. So, so far, this is almost not quite a year. It's probably about 9 months data. The Scottish overall experience, the company that do the pathology reports, Cited, were kind enough to let me know this. We have done, at this point, about 1,400 reports we had back. We are getting sufficient samples in about 90% of patients. In the Barrett's group, we were finding either atypia or p53 positivity in just under 20%, which was a bit higher than we expected. And we're actually finding quite a large proportion of patients that didn't have intestinal metaplasia within our Barrett's group. In the reflux patients, we have less experience with this. There's a couple of areas that have really taken this on and are getting good experience with that. But similarly, what's our atypia p53 positivity rate? It's about 4.5%. And what is the proportion that have got Barrett's esophagus? And that is around 10%, which is the classic quoted figure for patients with reflux attending for endoscopy. So these are the sort of things that we are seeing, and we'll look into that a wee bit more detail. I've got a bit more of a handle on the Greater Glasgow and Clyde experience. About 2 weeks ago, just so I had all the pathology results, I looked at what cytology reports we were getting back. Now, I'll maybe just go to the bottom one first of all. We said for Scotland in the Barrett's group that it was about 30% of patients that didn't have intestinal metaplasia. And we were finding about a quarter of our patients didn't have intestinal metaplasia. I have got full handle on these patients. I've been through all of their previous endoscopies and previous biopsy results, and there were a large proportion that were on Barrett's screening and had 3 or 4 scopes over 10 years or whatever. And when we went back, they never had a cytology showing intestinal metaplasia. They probably had a irregular Z line, and somebody had found a Barrett's case on their list, had just done the biopsies and arranged a repeat scope for 3 years. So actually, it's a good point to take stock and say, do we need to be scoping all these patients? So I have quite a large number who have been reported as no IM that have said they don't need follow-up anymore. There are a few where I've gone over the pathology reports and they have said there's been definite IM on their biopsy results. The vast majority are C0M1 query Barrett's that I don't think are Barrett's, but there are a few that I've arranged for a repeat cytosponge in 6 months' time just to check, do we need to continue screening or not? But within the patients, the remainder of the patients, we had about 10% of our Barrett's patients who were reported as atypia or dysplasia. So dysplasia as in p53 positivity. Insufficient cells in about 5%, and these need repeats. We've had only 1 patient that's had 2 insufficient results, and we've just arranged a scope for them. But a large proportion of these patients have had intestinal metaplasia, and we've actually moved them out to their net surveillance interval. So the take-home figures are around a quarter of patients, no Barrett's, not tolerated in less than 5%, insufficient in around 5%, and a good number of them were able to get to their next surveillance interval. I've had a wee bit of caution with this. As I say, new technology, we don't know what's happening. We're keeping a very close eye on every single patient. I've looked at endoscopy reports for patients that have just come back as IM, but they're C14M14 or C11M11. And I'm just wondering, do we need to keep a closer eye on these people? And I've actually, a couple of them arranged their surveillance interval for 2 years rather than the 3 or the 5 years. Younger patients with Barrett's, younger patients with definite Barrett's. Again, if you've developed Barrett's at a young age, are you at more of risk of progression? That's another question I have. Maybe something we can discuss at the end of the meeting. What do we do with them? And if there's patients who have had a family history, do we keep a closer eye on them? So that's all things that I've been thinking about, and be grateful for any thoughts at the end. But reports have either atypia or p53 positivity. Now, we have grouped them together. I wondered initially, if we had atypia, should we just be repeating cytosponge in a year's time? But we didn't want to miss anything. We weren't sure enough of our follow-up, and maybe in a year's time, that's what we do. But at the moment, we are scoping everybody that has either atypia or p53 positivity. These numbers obviously don't correspond to the numbers in the previous slide, but I only have about just under 30 patients who have had full endoscopic assessment and biopsies have come back. So the atypias and p53s lumped together, 20 of them, when we scoped them, only had intestinal metaplasia. We had 3 patients in the atypia group who were indefinite for dysplasia, and all of the dysplastics and the adenocarcinoma came from the p53 positive side. So of the patients that have required a scope, we are finding pathology. And going back to speaking to these patients, these were all asymptomatic patients who were staying away from hospital because of COVID. If we hadn't had access to cytosponge, I think they would still be waiting for their endoscopy. So that's what we're finding. Just a couple, everyone likes nice pictures, a couple of examples of the sort of things we're seeing. One of the first ones was a patient from Inverclyde who had C10, M10 on their last scope. It was at that time a simple IM, no dysplasia, but they attended for cytosponge, and these are the actual cytosponge findings. So these are the sort of pictures that they get. So the sponge opens up and it gets the cells which form a block, and we can see from the pathology that there is atypia in the esophageal cells, and then the p53 stain shows overexpression of the p53 gene. So we asked for an upper GI endoscopy for this patient, and 2 definite areas of nodularity. The patient then had these biopsied, which showed intramucosal cancer, suspicious of early invasion. We wondered about endoscopic treatment, but actually it was felt that esophagectomy, when we put them through the MDT, would be the best treatment for this patient after a staging EMR. So I think we were concerned about margins at the EMR. So they had a esophagectomy. There were some residual cells in the esophagectomy specimen, but it was reported as a T1A esophageal cancer with no nodal disease. So an asymptomatic man who got surgery for a very early disease, which we're hoping is curative. The next patient, similar, the short segment of Barrett's, completely asymptomatic. He had an aberrant p53, so I scoped him after he'd had his cytology result back. This is the narrowband imaging findings of that. A couple of areas we're concerned about. You can see that big patch that was there. He went on to have an EMR, and that again showed a PT1A specimen, but we're happier with our margins with him, so he's undergoing endoscopic surveillance. So again, hopefully cured before it becomes a problem. Lastly, I've got a case that Ian Penman from Edinburgh was kind enough to let me see the slides. So this isn't included in our area, but this is a man who underwent an AMR, and Ian had some lovely pictures of his EMR specimens. So this is the sort of thing. Again, no symptoms. 3 years from his last scope. We don't know how long it would have been before he got his next scope, but this is what we're wanting to do. We're wanting to identify these lesions. We're wanting to perform an EMR, and then when we've got flat Barrett's, we're wanting to ablate the rest of the mucosa. So my experience in Glasgow has been more of the use of Barrett, of the cytosponge in a Barrett screening program. And I have found that around a quarter of patients may not actually have Barrett's. We have found it's a well-tolerated procedure, and we're finding about 10 to 12% of patients that we're needing to scope, and so far we're identifying pathology on the patients that have had their scope and their full biopsies back. So I'll be happy to take questions on this at the end, but hopefully that gives you an idea of the things that we've done when we've been starting, and what some of our outcomes are, and how we're dealing with the follow-ups. Thank you very much.
Paul, fantastic. Thank you so much for that, that talk. It was really interesting. What I found really quite staggering is we talk a lot about cytosponge in terms of its dysplasia pickup. And that's obviously something we're going to talk about more tonight. But I really like the fact that also you almost flipping it on its head there and saying, actually, we also found those people who didn't have Barrett's, who we're performing unnecessary invasive procedures on, and wasting money, wasting all sorts of resource on. Is that something you're going to, really look to take forward, maybe using the cytosponge as a way to sort of screen that out?
Well, it's it's been one of the things that we were looking at to try and rationalize our endoscopy was the advanced vetting. And it really is getting to the point where somebody who has got a sensible Barrett's head, that understands the disease, looks at the previous pictures, looks at the previous biopsies and makes a call on that. I think we weren't expecting that. I think it is what happens when you take a device out of the very controlled trial setting. All the patients that were entered into the BEST studies were all known Barrett's, had a scope by somebody who was interested in Barrett's before, but we're more getting a real life picture of an endoscopy service where not everybody is as interested as probably the people that are on this meeting are. So I think that has been very valuable, and I can understand it. I can understand someone at the end of a colonoscopy screening list finds that somebody's shoved on, an administrator has shoved on a 12 centimeter segment of Barrett's or a C0 M1 Barrett's. They're just going to deal with that without proper assessment perhaps, and without too much thought on it. So really we're hoping to move towards dedicated Barrett's lists, which we don't have in our area. And I think this will highlight that Barrett's should be done by people with an interest in Barrett's.
Thanks. I mean, I think it's interesting. Matt, I might come to you a little bit for this. I mean, I think it's interesting because we always look at this with the fear of dysplasia, don't we? Oh gosh, we're going to miss a dysplastic lesion. And the question is, do we trust cytosponge? Which we're going to address as we come on here, that we probably do trust cytosponge in terms of picking up dysplasia. But I suppose, can we trust it on the other end of the scale and say, if someone's had cytosponge twice, let's say, and they've not got metaplasia whatsoever, and as we talk about, it's less than C0 M3, do we just say that's enough? No need to scope this person at all. We're happy.
Yeah, no, I think this is a good point, and I think there are two areas which I want to highlight in answer to your question. So first one is the quality of the endoscopy, and obviously we know from published literature is that the longer the Barrett's, the lower is the adherence to the Seattle protocol. And I think Paul has made the point of the C10 M10 patients coming to the end of the list. Who is going to take the Seattle protocol biopsies? Very few. And that's because we are burned out. It's a difficult protocol to perform both for the endoscopies and the patient. So the adherence is key. So if we don't adhere to the protocol, perhaps a panesophageal sampling might be actually even better than the endoscopy. But I also want to make the point that even in an expert setting, so we've recently completed a crossover randomized trial looking at advanced imaging and biomarkers. And in one arm of the crossover trial, the patients had just white light endoscopy with Seattle protocol biopsies. And these were all done by expert endoscopists that knew how to identify lesions and knew how to take Seattle protocol biopsy, which were mandated by the protocol. Nevertheless, looking at the overall histology, including the histology in a year before the referral, the sensitivity for dysplasia was only 50%. So, I mean, we are obviously worried if we don't look. But then if we actually look at the data, even if when we look and we apply the Seattle protocol, flat dysplasia is really difficult to pick up. And, that's where we have to start from.
I think that's a really good point. I think it's exactly quality of endoscopy. But Vinay, forgive me if I'm going to ask you a basic question, maybe for you, Vinay, but I think it's really important for everyone to understand. You've got a 10 centimeter segment of Barrett's. How do you actually look at it? Matthew just talked about white light there really not being good enough. What do you do? Just talk us through when you've got a long segment of Barrett's or whatever else, what are you doing with your endoscope to actually find that dysplasia?
Yeah, thanks, Dave. It was really good talk, Paul, by the way. I really enjoyed it, really interesting data. So I think you've got to go back to the basics here. So when I do Barrett surveillance, I tend to offer sedation to these patients. They need to be sedated, be very comfortable during the procedure, particularly if you've got a long segment of Barrett's there. You don't want to be doing it with throat spray where the patient's thrashing around. And as Massi alluded to, flat dysplasia can be really difficult to detect. And you need to use your image enhancements, whether that's narrowband imaging, eye scan. Go back to basics, clean the Barrett's mucosa, give it a clean. You can use N-acetyl cysteine if there's a lot of sort of bubbles there. and take your time. So if you've got a 10 centimeter segment of Barrett's, which is what you asked, Dave, you should really be spending, the data would say, about a minute per centimeter of that, and really having a look. I found with experience, obviously with expert eyes, you can often find dysplasia if you look hard enough and you spend the time and you invest the energy during your surveillance case, you can find it. There's obviously other adjuncts that you can use, like acetic acid, which is obviously very popular and been very well described. But we do need to remember with the Seattle protocol, I know it's the gold standard that we allude to, but you still only sample about 5% of the Barrett's mucosa. So you are subject to potentially missing a big sampling error there. And that's one of the potential big benefits of the cytosponge, where you are getting, as Massey described, a pan-esophageal biopsy. I'd like to ask Paul, actually, because obviously our data is really interested to see your data. So what did you do with those patients that didn't have Barrett's according to the cytosponge? And you went back and you looked at their notes and you realized actually they didn't probably have Barrett's to start off with, because we've seen a bit of that as well. Did you call the patients and discharge them? And if so, how did they take it?
Yeah, I've written to the patients. I've written and I've said that after careful consideration and looking over their previous endoscopy results, pictures and biopsy results, they don't have, the way I've worded it is, they don't have any of the intestinal metaplasia cells that we're most worried about, and that we think that we don't need to do any further surveillance from them. I've not, at the end of my letter, I always say if there's any change in your reflux or problem swallowing, we may need to do a camera test in the future, but we've not organised this just now. So cover myself a wee bit, but I've not had any comeback from anyone saying, oh, I want to stay on Barrett's. We've not had people contacted so far.
I think it's very important that the endoscopist actually starts paving the road for the discharge. So it's very important to talk to the patient. If we feel that it's not something that is likely to be worthwhile surveying, we can start chatting in the endoscopy room or afterwards. And the other thing, I think it's important, whoever reviews the results feels him or herself confident of making a decision, because often these patients are just flagged for Barrett's and they have a flag. Nobody is taking the responsibility to removing the flag. So it's important that whoever takes a decision actually is confident and is trained to send a letter out of a template or things like that.
Yeah, Massey, I would agree. I think that's been the problem over the years. They've come on a colonoscopy list and the endoscopist has just said, not fully understand or appreciated the pathology result and the findings, and has just said, repeat in X number of years.
And I think Danielle Morris, who I've not seen for a while, so hi Danielle, nice that you tune in, has just brought up a very good point. She was also echoing your findings, really, in terms of atypia and P53 positivity, but also pointing out that, they've had patients who are positive on cytokines for metaplasia with the marker. And then, of course, when they look, there isn't Barrett's there at all. And of course, that's because, as we know, the natural population, will have somewhere between 10 and 20% of us will have metaplasia in our cardia. And I suspect that's why you get those positive signs. And I think what we're saying here, probably, Paul, I think you probably agree, is we're not saying don't ever scope someone, perhaps, in this instance. We're just sort of saying you need to have that sensible overview, don't you, and oversight into it. I think that's probably what we're saying, which is sort of echoing what Danielle's saying.
Yeah, and I think as people with an interest in Barrett's, we do good, as Vinay described, we do a proper assessment of Barrett's, but that isn't reflective of the overall surveillance practice that I've seen in Glasgow. Even, getting a C and an M description or adherence to Seattle protocol biopsies is far from 100%. And I would agree with Massey that the cytosponge gives a better sampling of the esophagus than our program with lots of different endoscopists does.
Yeah, I think that's right. So Paul, look, we've got a minute left. So I just wonder if you could just tell us. I'm only going to give you a minute, I'm afraid, Paul, but a minute to say what is next for Scotland. What are you guys going to do with the cytosponge next, you think, in your view?
Well, I think we are gaining a good experience. Fife and Lanarkshire are getting a very good experience of the use of it in primarily esophageal symptoms, and with a nurse assessment are able to avoid endoscopy in a lot of patients that traditionally would have come for endoscopy. So the diagnostic part of it, I think, will be rolled out. I think we're happy with its use in Barrett's. There's also we talked about the big numbers that are waiting to be assessed. Is there a role for a triage to having an endoscopy or not having an endoscopy after cytosponge in these patients who are just waiting for a scope, who have been waiting over a year, so probably don't have cancer?
Yeah, I think that's right. Thank you so much, Paul. Great talk. We're going to move on now to Vinay Sehgal, who has really, I'll say this now whilst he's on the line so he hears, I've admired internally for just how much work he's put into getting the cytosponge service underway in UCLH. He's done a really fantastic job, and we'll move on to his talk and hear about what data he's collected.
Good evening. I'd like to begin by thanking the team at Gastro Learning and Medtronic for the invitation to speak with you this evening. My name is Vinay Sehgal. I am a consultant gastroenterologist and interventional endoscopist at University College Hospital in London. I have a specialist interest in precancerous lesions of the upper GI tract, including Barrett's esophagus. I would like to spend the next 20 minutes or so discussing with you utilization of the cytosponge device to help risk stratify patients that were otherwise overdue Barrett surveillance during the COVID-19 pandemic. I'd like to present with you some background data on the device itself, the implications of deferring endoscopic procedures during the COVID-19 pandemic, and how we set up our service. I would like to finish off by presenting some data that we have collected so far and some future ideas for research moving forwards. These are my disclosures. Despite advances in surgical and adjuvant therapies, the majority of patients with esophageal adenocarcinoma present at an advanced disease stage. Despite improvements in survival over time, the 5-year survival still is only 16%. Barrett's esophagus is a well-established precursor to esophageal adenocarcinoma, with an estimated risk that is 30 to 60 times higher than that of the general population. The pathogenesis is now well understood, and we think that due to chronic acid reflux, there is a change in the lining of the esophagus from normal stratified squamous epithelium to non-dysplastic Barrett's esophagus with intestinal metaplasia. In a proportion of patients, they can continue to progress through to low and high grade dysplasia. And as you progress through this pathway, your cancer risk increases at each stage. It is generally accepted that patients with high-grade dysplasia should be offered endoscopic eradication therapy, and those with confirmed low-grade dysplasia should also be offered this. However, early stage of diagnosis is key. We know that the risk of nodal metastases in patients with disease confined to the mucosa and superficial submucosa is low, and therefore these patients would be amenable to endoscopic eradication therapy. However, if disease is more advanced and includes either the muscle or serosa, the risk of lymph node metastases increases significantly, such that these patients are usually offered surgery or chemoradiotherapy as appropriate. For this reason, although there is a lack of randomized data, endoscopic surveillance is generally recommended every 2 to 3 years, using quadrantic biopsies through every 2 centimeters of the Barrett segment as per the Seattle protocol. On the 11th of March 2020, the World Health Organization declared COVID-19 a pandemic. This led to major changes in the structuring and allocation of healthcare resources. This was a particular issue for the GI and endoscopy units, as COVID-19 houses in the aerodigestive tract. We were therefore faced with a challenge of how to manage our already stretched waiting lists and validate and triage overdue patients. Numerous position statements were released by both the European and international societies, and the general consensus from the BSG was that surveillance procedures, which included patients with Barrett's esophagus, would have to be deferred until further notice. This led to a significant reduction in endoscopic activity across all units in the United Kingdom, as it's quite neatly presented in this publication by Matt Rutter's group earlier this year. A modeling study looking at the 4 major cancers, including breast, colorectal, lung, and esophageal cancer, looked to understand what the excess cancer mortality may be from these 4 major tumor groups. Scenario A is the best possible scenario, and scenario C is the worst possible scenario. With regards to esophageal cancer, they predicted an increase of up to 6% of cancer-related deaths due to the COVID-19 pandemic up to 5 years from diagnosis. This has led to numerous challenges. We were faced with a situation where we were having to protect patients and healthcare professionals alike, but in the meantime, continue to establish a safe environment for emergency procedures. We were often having to triage and clinically validate already growing waiting lists and communicate our decision-making process to patients. As part of this approach, we also explored non-endoscopic approaches to managing these patients. An example of this is the Cytosponge device. The Cytosponge device is a well-tolerated, non-endoscopic, minimally invasive cell collecting device. When combined with a biomarker called trefoil factor 3 or TFF3, it is able to diagnose patients with Barrett's esophagus containing intestinal metaplasia in over 90% of cases. It consists of a 30mm polyurethane sponge enclosed in a capsule. It is swallowed by patients and after approximately 7 minutes retrieved and takes a biopsy from the distal esophagus. The Cytosponge device can be thought of as a non-endoscopic biopsy. It offers an attractive, less invasive sampling approach compared to conventional endoscopy. Patients do not require sedation. There is limited manpower required. It can be performed in an outpatient setting or even outside of a hospital, and has been found to be more cost-effective than endoscopy and biopsy. There was also data to show that the Cytosponge is better tolerated and accepted by patients compared to endoscopy without sedation. Since it was first described, there has been a wealth of large-scale data looking at the Cytosponge device, including the BEST 1, 2, and 3 studies. In total, there have been nearly 3,000 Cytosponge procedures performed in nearly 2,500 patients. The device has been successfully swallowed in nearly 97% of patients with only 2 adverse events. One was a minor self-limiting pharyngeal bleed, and the other was detachment of the sponge, which was retrieved endoscopically. There has also been more recently published randomized data, which has looked at the detection rate of Barrett's esophagus compared to standard care in patients that were offered the Cytosponge. This study showed that there was a 10-fold increase in Barrett's detection when the Cytosponge was compared to usual care in the primary care setting. There are also numerous biomarkers that we can look at with regards to the Cytosponge. The first, as I previously described, was trefoil factor 3 or TFF3, which in essence is a marker of intestinal metaplasia. The Cytosponge can also be evaluated for molecular abnormalities on immunohistochemistry, including P53 and urokinase A and cellular atypia. These biomarkers, when combined with clinical and demographic data, have been used and shown to accurately identify a group of patients that are at low risk of progression, from whom endoscopic surveillance could potentially be avoided. We therefore decided to use the Cytosponge to help triage and risk stratify patients that were otherwise overdue Barrett surveillance endoscopy during the COVID-19 pandemic. We performed our procedures in an outpatient treatment room on the floor below our endoscopy unit. After close discussion with our virologists and infectious disease team, the procedure was deemed to be non-aerosol generating, which meant that minimal personal protective equipment was required. There was no requirement for sedation, and the total procedure time, including the time that the patient came into the room and left, was approximately 20 minutes. We were able to perform up to 12 patients per list, and the lists were often performed by either nurse endoscopists or healthcare assistants. Endoscopic support was always available in case of an emergency. So the procedure was performed by nurse specialists and research fellows who all went on a dedicated one-day training program, which included case observation and hands-on training in Cambridge. They were also trained on the consent process and the important logistical aspects to discuss with patients. In our experience, the learning curve was relatively short, with only 5 cases needed. And once people were performing the procedure, we would recommend application for independent status after 20 cases. What I think was very important was regular communication between us and other units performing the cytosponge procedure for continual learning and sharing of experience and events moving forwards. So we offered the cytosponge to 2 groups of patients. We offered the first to treatment-naive patients who were already in the Barrett surveillance program. These patients had to be fit for endoscopy. They would have had no history of dysplasia previously, and also no history of strictures. We only offered this to patients who had a Barrett's length of greater than or equal to 2 centimeters. Further down the line, we began to offer the cytosponge to patients who had had endoscopic eradication therapy and were deemed to be at low risk of recurrence. So this included patients that were more than 18 months from complete resolution of dysplasia, with no history of stenosis and no previous exposure to photodynamic therapy. The preparation for the cytosponge procedure was very similar to that with diagnostic gastroscopy. So patients would have to be nil by mouth for 6 hours. As there was no sedation required, there was no requirement for an escort, and anticoagulation measures were taken to mirror that from the BSG or ESG guidelines. We devised a patient information leaflet which housed all of this information, which was sent in advance to patients before their procedure. So this is a useful flow diagram that we put together that divided the 2 groups of patients and explained what measures would have to be taken with regards to anticoagulation. This was used by the team that was scheduling patients in for the cytosponge procedure, but was also available to nurses and research fellows during the procedure itself. There are some important exclusion criteria that I would point you in the direction of. So patients who had known cancer, obviously not appropriate. Patients who'd had previous surgery, including esophagectomy or anti-reflux surgery, were also excluded. And also patients who'd had previous photodynamic therapy were excluded from being offered the cytosponge. So we developed the following algorithm to try and risk assess and provide decision-making advice on these patients. So in patients who did not accept the cytosponge, we explained to them that we would be able to then perform their endoscopy as soon as possible. In those that did accept the cytosponge, we divided the outcomes into 3 possible categories. So patients who were positive for TFF3 but negative for P53 or atypia were deemed to be low risk, and we would therefore offer them a repeat endoscopy within 12 months of their cytosponge, or 6 months if these were for post-treatment patients. Patients who were negative for all 3 markers, we were although this was a low risk result, we were slightly concerned that this may not have sampled the distal esophagus. So we would initially offer these patients a repeat cytosponge. And if they did not take that up, we would offer them a repeat endoscopy whenever possible. Finally, patients who were positive for P53 and or atypia, we classed that as a high risk result, and we would offer these patients an endoscopy within 3 months. Now, we treated P53 and atypia the same, as this was the first experience of doing this. We felt that it was important to be more cautious in our approach. We are aware that there is a multidimensional biomarker panel that has already encompassed clinical risk factors, as well as P53 or urokinase A, and that is able to detect high-grade dysplasia in almost 90% of patients. However, we chose not to use this approach because it requires complex gene sequencing, and the Aurora A antibody is complex to score and no longer commercially available, so it's not included in our algorithm. We're also aware that the majority of the risk from previous logistic regression models has emanated from P53 and atypia on H&E, which is why we decided to use these 2 markers in conjunction with TFF3 when using and developing our cytosponge algorithm. So from a governance perspective, all of our cases were reviewed in a Barrett's MDT, and all of the results were communicated to patients and GPs in writing. High-risk patients who required an endoscopy within 3 months were contacted via telephone, in addition to having communication sent out so that we could schedule their endoscopy accordingly. Patients who declined the cytosponge remained on the waiting list, and their endoscopy was performed whenever next available. So if we come to our results, we had a total of 429 patients who were enrolled in the Barrett surveillance program that were invited for the cytosponge. 20 patients declined and 70 patients were unsuitable as per the criteria I have previously discussed, meaning that the total number of patients which were suitable for the cytosponge was 339. If we divide this into the total number of patients that have had their cytosponge performed to date, that is 161, with a clear predominance for males across all three groups, including that with no previous treatment, those with treatment. The median Barrett's length across patients in both groups was 3 centimeters, but please remember the patients in the post-treatment cohort by definition would have no visible Barrett's, hence why they were at low risk of progression and offered the cytosponge instead of endoscopy. So the initial results were that nearly 10% of patients actually required a repeat cytosponge as there was insufficient tissue collected on the initial sample. We had 2 patients that were unable to swallow the cytosponge, and we also had 2 cases in which we were unable to treat the cytosponge. Fortunately, both of these cases were retrieved endoscopically. One was due to cricopharyngeal spasm, and one was trapped within the wrap of a fundoplication, after which we excluded these patients moving forwards. We did not experience any cases of sponge detachment, bleeding, or any other serious complications of note. If we begin by looking at the group of patients that had no previous treatment, we can see that 80% of these patients were triaged as having a low risk result and were therefore offered an endoscopy within 12 to 24 months, and they are awaiting their endoscopy findings in due course. If we, however, concentrate on the group of patients that had a high risk result, we can see that there were 20% which fell into this category. So in the first of these groups, we can see that 5 patients were negative for TFF3, but either positive for atypia or P53. 2 of these patients have since had an endoscopy with no dysplasia identified. In both of these patients, they were positive for atypia only and not P53. In the next of these groups, in patients in whom they were TFF3 positive, but also atypia and or P53 positive, 19 fell into this category, of which 18 have since had an endoscopy within 3 months. We can see that 10 of these patients had dysplasia reproduced on endoscopy and biopsy. This therefore means that of the 20% of patients that had a high risk result, half of these had endoscopy and biopsy proven dysplasia thereafter. 20% or 4 of these patients have since proceeded to endoscopic eradication therapy, and the data that we have to date would suggest that P53 appears to be the most sensitive marker of predicting dysplasia, albeit in the small number of patients. This is an example of one such case. This was a 67-year-old gentleman who had 8 centimeters of circumferential Barrett's, who was in the Barrett surveillance program with no history of previous dysplasia and any biopsies. His cytosponge was positive for atypia and P53 on H&E and immunohistochemistry. When this gentleman came for his endoscopy, he was once again found to have a long segment of circumferential Barrett's. After acetic acid, there was an area on the posterior wall which lacked acetyl whitening, which was evaluated using image enhancement, where he was found to have a biopsy was taken, which revealed high-grade dysplasia. He therefore went on to have a repeat endoscopy and was offered endoscopic mucosal resection of this area for staging. The lesion itself was once again identified, and thereafter it was marked using the tip of a snare, and then a multi-band mucosectomy device was mounted onto the endoscope to remove the lesion in question, as you can see here. The lesion itself was removed uneventfully, and the subsequent histology confirmed high-grade dysplasia, which you can see here. Since then, he has had a repeat endoscopy where no visible dysplasia was identified, and he was offered radiofrequency ablation to his residual Barrett segment to reduce the risk of recurrence, and is ongoing with his endoscopic therapy as we speak. If we next look at the group of patients that have had previous therapy, we can see that we have had 24 patients so far, of which 5 needed a repeat procedure in total. So 24 of these patients have had their cytosponge evaluated. And only 2 of these patients had a high risk result as per the previous criteria. 1 of these were found to have atypia, and the other patient was found to have high-grade dysplasia. So 2 out of 24 patients, i.e. just less than 10%, had a high-risk result. 1 was a new case of recurrent high-grade dysplasia, which has been successfully treated endoscopically. This is an 87-year-old gentleman who's had a previous EMR and RFA for high-grade dysplasia at Barrett's back in 2014. His last endoscopy before the cytosponge was in August 2019. He was reported to have no residual Barrett's. Biopsies from his neo-OGJ and his cardia revealed no intestinal metaplasia or dysplasia. On his cytosponge, which was performed in June of this year, he was positive for TFF3 and P53, but negative for atypia. So he was found to have some nodularity at the cardia with, again, crowding of the crypts, probably lack of normal crypt pattern in the center here with some slight depression and some dilated irregular blood vessels. The lesion itself was removed by endoscopic mucosal resection, the histology of which is confirmed high-grade dysplasia with a negative deep resection margin. I can tell you now that the patient is well, with no dysphagia moving forwards. So it is important to briefly discuss cost effectiveness. So we know that the cost of an endoscopy at UCLH is £540, and that histology costs £165 per level. Given the fact our data shows that patients have on average 3 to 4 centimeters of Barrett's, this will require 3 levels of sampling. There'll also be the cost of a nurse endoscopy session for 4 hours, as well as the cost of sedation and recovery. When we compare this to the cytosponge, the device itself costs less than half than that of an endoscopy, and the cost of an HCA will be lower than that of a nurse endoscopist. Therefore, the cytosponge appears to be an acceptable, safe, and cost-effective non-endoscopic tool, which can be used to triage patients with Barrett's esophagus that are overdue endoscopic surveillance. In our cohort of patients, we have found that P53 appears to be the most sensitive marker of predictive dysplasia. However, nearly 10% of patients required a repeat cytosponge, and it is important to let patients know of this in advance before they attend for their procedure. We had 2 cases where we were unable to retrieve the sponge normally, but both were managed endoscopically. There were no serious adverse events, nor did any patients come to harm during our work to date. Further large-scale longitudinal data is needed to assess the effectiveness of cytosponge in the setting, and may well serve as an argument moving forwards to us performing less endoscopic surveillance and instead offering the cytosponge instead of endoscopy, but further data will be needed before we can make such decisions. Thank you for listening, and I will now be happy to take any questions back in the virtual platform.
Vinay, again, fantastic talk. Thank you very much. In our last chat, we talked about the need for quality endoscopy, and the data you present shows very exciting findings in terms of its dysplasia pickup. Do you think we're moving towards a position where we're going to trust our sponge and our panesophageal sponge more than we're going to trust endoscopists now? Is that where we're moving towards, Vinay, do you think?
Yeah, that's a really good question, Dave. I think although endoscopy and biopsy is the gold standard, we have to remember it's not perfect. And as with the Seattle protocol, there is a large sampling error if it's not done in a systematic way, as we've discussed earlier. Although endoscopy may appear to be sort of the panacea of Barrett surveillance, it's far from perfect, and it would be useful to look at the data comparing dysplasia detection within a cohort of patients who've had no treatment before Barrett's with that off-site sponge, and then you'll be able to better make the argument and protect cohort of patients. I think there's other things to think about as well. So we always need to remember about things like risk factors. So family history, someone's got 2 or 3 first-degree relatives with esophageal cancer, particularly if they were young, think I'd be slightly anxious from not offering them endoscopy. So there is a bigger picture to it, but I think right does require for thought moving forwards. I don't know what Massey thinks about that. What are your thoughts on, because we're now kind of seeing the data come out in a real world way, Massey, and that was really exciting when we set the project up outside of a trial setting. I don't know what your thoughts are on that, Massey.
So I mean, I can tell you that we just submitted our data on the combined analysis of the best 2 and best 3 study cohorts. We looked at the accuracy of P53 and atypia as biomarkers for detection of high-grade dysplasia in intramucosal cancer. The area under the curve was 0.8 in the training cohort and 0.86 in the validation cohort. Adding the clinical data, in particular the age and the length of Barrett's, only marginally improved the diagnostic accuracy. So the overall sensitivity for dysplasia was between 75 and 80%. Again, obviously, this is not perfect, but it goes back to the discussion we had before, and we were just having now, that endoscopy is not perfect either. So I think I think we can trust the cytosponge. Obviously, we haven't resolved the issue of getting 100%, and we probably never will. But I think it's an effective strategy if used in a sort of controlled context.
Brilliant. Thanks, Matthew. We're getting loads of questions coming in from the audience, which is really great. And thank you. We'll keep posting those questions and we'll try and get as many of them answered as we can. Andrew, I'm going to save one of your questions actually till after Massey's next talk, actually, because I think it will fit quite nicely there. But I'm going to start, Paul. I want to, because I know the answer to this in probably Cambridge and UCH, because Cambridge basically invented the cytosponge and brought it forward, and UCH, we've embraced it fully. But in your world, a question from Sunitha Rajan, how did your colleagues, feel about, saying, like, do you know what, endoscopy's over, guys, let's put this sponge down? How was it received? Were people skeptical or happy?
Yes, there was skepticism, and I think part of that is we are essentially using it in a setting where there's no evidence. Now, we've been kind of forced into that. I think there is evidence of the sensitivity and specificity, but it has not been developed or advertised as a tool to survey Barrett's. And Vinay's excellent talk and excellent pictures, I thought were great, just say that. But I think the important thing that I've taken is what I'm hoping to champion in Scotland as well. We really, really need to, having been given this opportunity where we can use it because we don't really have an alternative, we really, really need to use this to closely audit our outcomes and what do all the scopes show of the patients who've needed it. If someone, in the group that didn't get a scope, how many of them run into problems? So we're looking at real life data here. There has been a lot of skepticism. There has been people saying, we can't do that, that's not allowed. But we've made a governance decision that given we can't scope these people, we have to do something.
And I guess, Paul, sort of moving on, you sort of briefly touched on another question we had from the audience, actually, from Anjan, I think, again, about, when the sponge is positive, are these lesions big obvious lesions we're never going to miss any, or are they actually then some subtle or even invisible displays? What's been your view? Maybe then we'll move to Vinay and Massey for that, to get an overall picture. What sort of displays are you finding?
Yeah, when we found dysplasia, it's been very limited to the number of endoscopists that are doing it. So I can't say if these had turned up on a general list with someone plowing through a 12-point list, if they would have seen it or not. Because we've had a warning that there is probably something there. It's like when you're scoping someone with a strong family history of gastric cancer, you really are looking for this most subtle of lesions. So I can't really answer that. We have had a little bit of warning that there's something going on in this patient's Barrett's. We have really looked carefully at it, and it's been our best endoscopists that have been doing that. So I don't know the answer to that if they had been on a general list. Now, maybe that does go back to the previous question, because the vast majority of people that end up doing some Barrett's, they're not that interested in it. They're quite glad to give the Barrett's over to somebody else who's got an interest. So I think eventually we will have a lot more acceptance of this.
And I guess it's a bit like using, GI Genius, AI for the colon. You get a warning, don't you? There might be a polyp there, and suddenly you're all eyes. Vinay, should we go to you before Massey? Dysplasia, was it visible? Was it obvious? Was it? Do you think subtle? I mean, the video you show was quite subtle. So my answer to that would be that was quite subtle.
It was a bit of a mixed bag, really. Some of the stuff was a bit more obvious than others, but like Paul said, we had a forewarning. We had that signal before we went in, and we've kind of selected a cohort of expert endoscopists with a specialist interest in Barrett's to do the cases. It would be interesting, I think. Who would we decide to do the low risk patients moving forwards? Are we going to put them back onto regular lists like we did pre-COVID, or are we going to get the experts to do it again? I would argue the latter probably would be a better scientific approach to the question. And obviously you always have that question, because the low risk patients are the ones what we classed as low risk are the ones that I worry about a little bit more, because the high risk patients are going to have their scope pretty soon. The low risk ones, you do worry, are you sitting on something? Maybe not. And potentially will that change over time? So that window, that 12-month window that we've said, there is always a possibility that they will have developed dysplasia in that time between doing the sponge and them having their endoscopy. But I think that data will come out in time when they've all had their endoscopy. I think then I have more informed understanding of the data so far. But coming back to your question, it's been a bit of a mixed bag. Some stuff is really subtle, and I honestly, my hand on my heart, if I didn't know that the cytosponge was positive, I may well myself have overlooked it. So your eyes and your ears are all kind of completely kind of on high alert for it, and I think that is relevant to what we're saying.
Yeah, no, thank you, Vinay. We'll move on to Massey's talk, but Massey, before we move on, just I guess a quick comment from you about whether, like we're talking about, almost like is the cytosponge performing a warning or a helpful addition to our Barrett's surveillance? Do you see our surveillance intervals being affected with perhaps a cytosponge being placed in amongst the surveillance or as an adjunct to the surveillance?
Well, I mean, I think I'm going back to the point that we can't really say much until we get the results from the endoscopy of the cytosponge low risk results. I think we should be more careful, and that's why I said using that is good, but in a very controlled way, auditing the results of the endoscopy follow-ups. And I think that's the key. In addition to that, I think the clinical factor do play a role. So what we see in the analysis of our data set is if we use the length of Barrett's as a safety net for prioritizing our follow-up endoscopies, allows us to improve our sensitivity towards dysplasia, because very, very long segment of Barrett's, don't forget, have higher risk. And those are the patients that should be seen perhaps earlier.
Thanks so much, Massey. That's great. And your dedication to proper data collection is why you lead all the trials, and I get excited reading them. So look, let's move straight on to your Delta project, and let's hear your talk.
Cambridge University Hospital and senior clinician scientist at the MRC Cancer Unit. I have no disclosures apart from that of being endoscopy lead in the BEST3 cytosponge study. So after the first two talks on the use of cytosponge in a clinical setting, I'm going to present some data on the Delta project, which is a clinical research implementation project funded by Innovate UK. The Delta project is a really broad project, and it's about answering some important questions on the use of cytosponge in a clinical setting. Broadly speaking, it has four work packages. The first one is about the identification of individuals at risk of esophageal adenocarcinoma. The second work package is about assessing the logistics of clinical implementation of Cytosponge in a real clinical scenario. The third work package is more about the potential usefulness of artificial intelligence in assisting the histopathological diagnosis on Cytosponge samples. And the fourth work package is about health economics in the use of Cytosponge for esophageal adenocarcinoma and Barrett's esophagus screening. So I'm just going to briefly walk through the individual work packages. I will spend most of my time on the clinical implementation, but I'll touch briefly on the other work packages as well. So the first work package is focused on the identification of individuals at risk for esophageal adenocarcinoma. This stems from data, epidemiological data that have been accumulated so far on the risk profile of patients for esophageal adenocarcinoma. And this is very elegantly represented in this cartoon from a review from Vaughan and Fitzgerald, which is based on the US population, but we can consider that representative of the UK population, remembering that UK and US have a similar epidemiology of esophageal adenocarcinoma. We know that GERD is a gastroesophageal reflux disease is highly prevalent in the general population, with a estimated prevalence of 20% in the Western, in particular in the US and UK. However, only about 10% of this 20% will at some stage during their life receive an endoscopy. And we know that among patients with GERD having an endoscopy, about 5 to 10%, so representatively 8%, will be diagnosed with Barrett's esophagus. Now, if we focus on Barrett's esophagus and the endoscopic surveillance of this condition to prevent or early diagnose esophageal adenocarcinoma, we know we will only manage to deal with about 7% of all esophageal adenocarcinoma, suggesting that the remaining 93% will actually happen within a surveillance setting for esophageal, well, for Barrett's esophagus. In particular, there is a large proportion, about 40% of all esophageal adenocarcinoma, that will actually not happen within a previous history of gastroesophageal reflux disease. And this really puts a clinical emphasis on the ability of us physicians, GI physicians, and GP of identifying individuals at risk. So there is a real need to identify, apart from GERD, what are the clinical factors that increase the risk for esophageal adenocarcinoma. And hopefully through the Delta project, I'm not going too much into specifics about the methodology, this area of this gray area will be better lit up. So moving on to the clinical implementation, which is probably what we are mostly interested in, we really would like with the Delta project to understand the logistics of the clinical implementation, which is partly also being highlighted by the previous two talks. So in the work package 2, we have recently introduced a primary care mobile unit, which has really helped the primary care side of the Delta project. This mobile unit is currently sitting outside one of the South Cambridge GP practices, the Granta practice in Great Shelford, and helps sort of covering two main areas of the primary care side of the work package 2. First of all, those individuals that are identified to screening of GP records as of potentially at risk for Barrett's esophagus and esophageal adenocarcinoma. And these are individuals with 50 years or more with records of repeat PPI prescription, excluding those that are already known to have Barrett's esophagus or had the recent gastroscopy. Aside of the screening of the GP records, we are also accepting self-referrals with the help of the Heartburn Cancer UK charity. This is focused on a similar age group, but slightly younger, so with a cutoff age of 40, and also who either self-medicate or receive prescription. And the difference is that it is not based on a GP record screen, but it's really achieved through either the advertisement of Heartburn Cancer UK or people that pass by the mobile unit and express interest in the screening. The mobile unit is quite comfy. There is a one-way system. This is the chair where the cytosponge is administered, and there is a large bench for the nurses for handling devices and samples. You can see one of the individuals receiving the cytosponge. These individuals are not COVID tested. They wear the mask up until the administration of the cytosponge. The nurse typically wears FFP3 mask and disposable protective measures. And so far, we have recruited to date 97 patients through the GP record screen and 47 self-referrals, of which 15 patients needed a second attempt because unable to swallow in the first instance, and that led to 6 endoscopies from positive findings at cytosponge. Going a little bit deeper onto the characteristics of this cohort, so the patients that have been screened have been identified as potentially eligible, have been about 500, of which 181 responded positively and eventually agreed to participate. We had 79 that refused participation, typically for concern about COVID or concern about being able to swallow the cytosponge, and 214 no responses. As also in the best 3, we have slightly more female. Female tend to respond typically more positively to screening initiatives. They are prevalent females in the 50 to 59 and 60 to 69 age groups, whereas in the 70 to 79 we had more males. So males tend to come a little bit later in their life in terms of positive response to screening. The primary care, the distribution of gender is similar. The majority of the patients, 86%, had previously seen GP for their symptoms consisting mostly of acid reflux, but also heartburn, or the combination of acid reflux and heartburn, less typically epigastric pains or other dyspepsia symptoms. In the work package to secondary care pathway, this is based on assessment in the hospital of routine referrals from primary care for patients with heartburn or dyspepsia. We are not recruiting patients with alarm symptoms that end up on the 2-week wait, which will receive a clinically indicated endoscopy. Those are invited to have the cytosponge test. And this also is offered as part of the Delta project to patients on Barrett surveillance. If the test is positive, then obviously, typically the patients will receive an endoscopy. If negative, is reassured and managed clinically, most commonly through a telephone consultation. The secondary care recruitment has been completed so far in 4 hospitals, Addenbrooke, Stevenage, Harrogate, and West Suffolk Hospital, and is currently ongoing in other 5 hospitals. Other centers are being trained, and 14 nurses have been trained so far, with 4 nurses trained as a trainer. The acceptability in secondary care is really good, with 98% acceptability. We have recruited so far 577 patients, of which about 2/3 to 3/4 Barrett surveillance, and about 1/3 of GP referrals. And repeat swallows have been needed in 4 cases. Average appointment time of just under 30 minutes, and the turnaround time for pathology reporting has been on average 8 days. So this is the breakdown of individual centers in terms of recruitment. The Cambridge University Hospital has recruited most patients, also because obviously we have provided a lot of training for other centers. The mobile unit has recruited about 15% of all patients. Among the other centers, West Suffolk and Leicester have done well, followed by Harrogate, Bedford, and Leicester Hospital. The majority of the patients, as we mentioned, have been patients on surveillance for Barrett's esophagus, and this is represented by the navy color. The symptomatic referrals have mostly been recruited between Cambridge and Leicester. Targeted screening a little bit in Cambridge, and mostly by the mobile unit. And the 10 patients, 10 patients here have been those recruited through the self-referral routes. What are the findings in the secondary and primary care? So first of all, in the adequacy of the cytosponge samples is really high. 97% in secondary care and 100% in primary care. So this is really reassuring, suggesting that the test is reliable and can lead to clinical information in the majority of cases. In secondary care, 49% had features of IM based on TFF3 positive staining. And this is obviously because a large proportion of secondary care recruits are on Barrett surveillance, whereas in primary care we had 5% positive TFF3 staining, and this is in keeping with the known prevalence of Barrett's disease in patients with GERD. Obviously here there is an issue about definition of GERD, and different centers in the literature have used different definition. We are mostly basing our definition on repeat PPI prescription. 7% of patients in secondary care had evidence of atypia, 11 of which were positive at P53. And 2% only had atypia, and this is obviously the difference is also due to different percentage of positive cytosponges in the 2 groups. So that is about sort of the finding. I'm not able to present today results on the findings at endoscopy. These are still being analyzed, and hopefully we will be able to present these results on a next symposium or webinar. I'm just going to mention a little bit about the other 2 work packages. The utility of artificial intelligence is mostly stemming from a recent publication from Rebecca Fitzgerald's group, where AI was used to identify on digital pathology area of positive staining for TFF3. So on the left panels here, you have cases of positive TFF3 signal based on the intensity and distribution of the TFF3 staining. The digital pathology slides is analyzed through the AI system, which is able to flag areas of positive or potentially positive through a semi-automatic system, whereby the AI system gives the confidence of the estimation. And if it's a low confidence estimation, then we'll need pathology review for assessment. And using this three-tier system, high, moderate, and low confidence, with pathologists review in case of low confidence, the system was able to reduce by 57% the workload for pathologists. So this was based on a training and validation cohort, and achieved similar level of sensitivity and specificity than in the previous publications. So the Work Package 3 in Delta projects will be about further validating the AI system in order to improve the efficiency and reduce the workload for the pathologist, which will be one of the limiting steps when hopefully the cytosponge will be fully implemented in clinical practice. And finally, just want to briefly mention the health economics about the cytosponge implementation in esophageal adenocarcinoma screening. This is a recent publication also from Rebecca Fitzgerald's group, where a Markov model has been constructed, which modeled a scenario with one-time screening at the age of 69 with confirmatory endoscopy, follow-up surveillance, and treatment if dysplasia or cancer detected. The assumptions here were a 59% uptake into screening, 39% uptake to screening, and a sensitivity for Barrett's 80%, and specificity of 94%, which is the data coming from the BEST2 study. And with this assumption, a screening strategy for Barrett's and esophageal adenocarcinoma led to a 0.015 QALY gained per patient at the extra cost of £82 per patient. Obviously, the low level of QALY gained per patient depends on the fact that only a small proportion of patients will be identified with cancer and therefore treated. But finally, the strategy was 97% likely to be cost effective with an ISA of £20,000 per QALY gained. So this is really promising in terms of cost effectiveness of cytosponge-based screening for esophageal adenocarcinoma. So I'm just going to conclude my presentation here, and obviously this is a several people work. It would be impossible to acknowledge all the people involved in this work. Obviously, Rebecca Fitzgerald needs to be acknowledged for her wonderful work so far on the cytosponge, and I would also like to acknowledge Abby Carriage, who is the study coordinator and has gave me a lot of help in preparing these slides and providing all the data on the current recruitment. I also would like to acknowledge UK Innovate for their funding, and HC UK for their incredible support for the mobile unit. And obviously, thanks to all of you for your attention, and I'd be delighted to take questions.
Massi, again, thank you so much. That's a really inspiring talk. I think we're showing really exciting times coming up for Cytosponge. I love the thought of a mobile Cytosponge units going around the country picking up cancer early. That's really exciting. Addressing a question we had earlier from Anjan Dar, do you think the Cytosponge can stand alone in terms of picking up these patients, or do we need to use things like the Edinburgh Dysphagia Score as an adjunct to it to try and get additional data to try and catch these patients?
I mean, in the COVID emergency, we have used the Cytosponge also in patients with dysphagia, and we did find that the combination of some clinical factors together with the dysphagia score and some elements on the Cytosponge, for example, the absence of TFF3 positive groups, probably because of an obstruction. I mean, it kind of was helpful, but we would not advocate the use of the Cytosponge in patients with dysphagia, which at the moment should still receive a clinically indicated endoscopy. The way I see it is that the Cytosponge would be an excellent tool in the clinic, where not necessarily, it has to be used as a diagnostic for referral, but could be actually used in a GP or in a gastro clinic as a tool that can be administered with the help, of course, of a nurse by the physician, and actually gather together information with, symptomatic information, family history, and all what we would take during a routine consultation. So I think in the future, that could be the point for diagnostic. Certainly for screening, the main crux of the point is to identify the right population. So I think that's our next step.
And Massi, I just one more question for you, if you don't mind. And do you think amongst all this, there's a risk that we ignore the stomach? We know that the esophageal and gastric cancers can present with similar symptoms. Do you worry ever that, brilliant, we've got the Cytosponge down, patients will go, well, I'm fine, I'm great, I haven't got esophageal cancer, I'm on my way. And then, it turns out they have a gastric cancer. How do you see sort of that playing out? We must be wary of that, surely.
Yeah, I think that was the original concern by the GP representatives of having a test which is actually only one organ test. And obviously the esophagus is the organ which is mostly sampled, but we are actually looking at the potential of Cytosponge to give us information about gastric pathologies as well. So what we saw in the BEST3 data set is that 40% of patients with TFF3 positive on Cytosponge did not have Barrett's esophagus. But we looked at the patients who had gastric biopsies in this subgroup. And actually we found that there was a high proportion of patients with TFF3 positive on Cytosponge, no Barrett's endoscopy, that actually had pre-malignant gastric pathologies like gastric atrophy and intestinal metaplasia. So obviously the Cytosponge is sampling the proximal stomach and could inform on the presence of extensive gastric IM, which is the high-risk gastric pathology. We are planning a prospective study, case control on patients with gastric pathologies, and we are also interested in looking at the supernatant of the Cytosponge to see whether actually we could run some assays like microRNAs or other biomarkers that could inform on gastric pathology as well. So we are actually expanding our interest into the stomach, and hopefully in the future we'll get some additional information on stomach pathologies too.
Oh, fantastic. Thanks, Massi. That'd be really interesting actually to hear about that maybe another time. Paul, coming to you, we've only got a couple of minutes left, and I think what we've heard tonight is really amazing data on dysplasia detection, excluding Barrett's, cost effectiveness, really positive data. I guess hopefully people are inspired to set up this service. And I think from you, and then I'll come to Vinay with probably a very similar question, what are your tips to setting up the service, and what barriers and hurdles did you hit, and how did you overcome them?
I think the main issue we did the nurses training, everything was a bit rushed during COVID. We should have sorted out where it was going to happen, how it was going to happen before we actually did the training. We were then scrambling around to try and find clinic rooms and time to do that. There's a little bit of logistics to sort out with getting specimens down to the lab. So I think that we would have had more of a plan, but as you can remember, at the start of COVID, everything was all a bit rushed. We were supported by Scottish Government. They put in a priming grant to get this going from an endoscopy rescue point of view. So we were lucky from that point of view. But it was starting off with nurses who can take a clinical history from the patient, who have a bit more of a leadership role within the endoscopy department, who will then go on to train other maybe lower banded nurses to take on this procedure.
Fantastic. And Vinay, coming to you briefly in the last minute or so, similar question. How was it funded at UCH? And what hurdles have you hit, or have there been no hurdles? Has it been so smooth?
No, I think so. The funding came through a COVID kind of mitigation fund from UCLH, which is designated to try and avoid missing cancers. And I think the real challenge was, and I think with experience you learn, the actual logistics, the nitty gritty of where does the sample go, who collects it, who looks at the result, putting together a process that's really robust. And I'm not going to lie, we learn from experience, and really thinking about every small detail about that, and finally communicating the results to patients, and also ensuring they have adequate endoscopic follow-up. So things like these, a lot of these patients, as we've seen in the data, don't actually have Barrett's esophagus, or by criteria alone should be discharged from endoscopic surveillance. Now, we have agreed to do an endoscopy on all of these patients that have the cytosponge, because we're taking it into a real world setting. But I suspect there'll be a large proportion that will not need ongoing endoscopic surveillance, and communicating that to them will probably be very, very important. So I think small details, think of them all, because it's the finest detail that'll let you down if you overlook it.
Fantastic. Thanks, Vinay. And Messa, I'm going to give you the last word as a Cambridge representative today. Tell us, just in a wrap up, where do you see cytosponge being in, let's say 5 years time? What's your dream, ticket for cytosponge at that point?
Well, I really hope that, as I was mentioning, it can become a tool that we can use in clinic. And I really hope that we can use it in the Barrett surveillance. So we are hopefully hearing very soon about the next CIUK grant on funding a large randomized trial looking at cytosponge in Barrett surveillance and the logistics to triage patients for endoscopy. So that's what I hope will happen in the next 5 years.
Fantastic. Thank you so much, guys. Massi, Paul, Vinay, really, really good. I've learned loads, and I'm really inspired by the data you guys have collected and the services you set up. So thank you so much. Well done. Keep up the great work, all of you. And I hope everyone enjoyed the show. There's a next webinar is on the 23rd of September, same time, 6 o'clock. And of course, it will be available on the platform to watch after that. That's quite an exciting day for GastroLearn, actually, because we have the esophageal neoplasia masterclass during the day, and then a lovely lead on to then this webinar. So I think it's going to be a really good esophagus day for people like me who love the esophagus. So please tune into both of those things. And thanks again, guys, for your great work.
Bye, everyone.